Hello, my name is Ari Javidan, and I'm the Program Coordinator for the National Consortium of Telehealth Resource Centers. Welcome to the latest presentation in the NCTRC webinar series, Innovation and Integration of Telehealth into Population Health. Today's webinar is hosted by the Northeast Telehealth Resource Center. These webinars are designed to provide timely information and demonstrations to support and guide the developments of your telehealth programs, and they are presented on the third Thursday of each month. Just to provide some background on the consortium, located throughout the country, there are 12 regional telehealth resource centers and 2 national telehealth resource centers, one focused on telehealth policy and the other on telehealth technology. Each serve as focal points for advancing the effective use of telehealth and supporting access to telehealth services in rural and underserved communities. A few tips before we get started. Your audio has been muted. Please use the Q&A function of the Zoom platform to ask questions. Questions will be answered at the end of the presentation. Please note that closed captioning is available and is located at the bottom of your screen. Today's webinar is being recorded, and you will be able to access today's and past webinars on the NCTRC YouTube channel. With that, I will pass it over to Reid Plimpton, Project Manager of the Northeast Telehealth Resource Center. Reid?
Thanks, Aria, and thanks everybody for joining. I'll be brief here. Just to quickly introduce myself, Reid Plimpton, Program Manager of the Northeast Telehealth Resource Center. We cover all of New England and New York. We're always happy to meet more folks, and we're always happy to connect you to your other TRCs as well. I'm honored and overjoyed to be joined by my friend and colleague, Dr. Michael Hasselberg, who we had the distinct pleasure of hosting at our annual conference this past fall, and we've been in touch with him since. I think he's got a lot of great thoughts to share, so I'll just give a quick bio on him, and then I'll be in the background as well. Michael Hasselberg is an associate professor of psychiatry, clinical nursing, and data science at the University of Rochester in New York. Dr. Hasselberg is the first chief digital health officer at UR Medicine and is a co-director of the UR Health Lab, the health system's digital health incubator. He was recently named to the 2021 Top 50 in Digital Health list by Rock Health to recognize his work to improve health equity through technology innovation during the COVID-19 pandemic. Board certified as a psychiatric mental health nurse practitioner, Dr. Hasselberg completed his PhD degree in health practice research at the UR and a postdoctoral certificate in healthcare leadership at the Johnson School of Management and at Cornell University. And with that, I think I will hand it over to you, Michael. Take it away.
Thank you, Reid, for that great introduction. And I'm really excited to be with everyone. I'm going to share my screen here and pull up my slide deck. All right. So today I'm going to talk about telehealth, but I'm actually going to talk about the bigger spectrum of digital health and where we're going at the University of Rochester and how we're pushing forward our digital health strategy as we're also moving into more value-based care as a health system, and where do we feel that this all fits in. So I have no financial relationships or disclosures to make for this presentation. And I'm going to begin this presentation actually in an industry outside of healthcare. And I'm going to talk about these two gentlemen up on the screen here. These two gentlemen totally disrupted the retail industry. These are two math majors from the University of Michigan, and they developed one of the first expert computing systems. Who you see on the screen here is Tom and Louis Borders. In the early 1970s, Tom and Louis tested their expert computing system in the book industry, and they stood up a bookstore in Ann Arbor, Michigan. And other bookstores, the Barnes and Nobles of the world, could not compete with this bookstore in Ann Arbor, Michigan. And the reason why is because they developed a computer system that could in real time track inventory, could figure out what consumers were buying in the bookstore, so they could quickly get those books back on shelf. So they had just a bigger selection and bigger bookstores than anyone else. And again, they leveraged computers to do that. Throughout the 70s, into the 80s, and into the early 90s, Borders rapidly grew. It grew throughout Michigan, down into Pennsylvania, and into New York State. It was actually in the 1990s that Borders kind of lost their edge in regards to innovation. Around the 1990s, well, actually during the 1990s, a lot of things were happening in the world. It was essentially the internet boom and the dot-com push during that time. And Borders decided to kind of stick what was working for them, which was, again, having these huge brick and mortar bookstores that were again larger than what anyone else had. And so they decided to actually partner with the Kmart Corporation. And if anyone remembers Kmart in the early 90s, Kmart was the leaders in regards to brick and mortar retail. They had a bigger footprint than anybody. Kmart had already acquired Warden Books, so it just made a lot of sense for Borders to partner with Kmart. Within a few years, the Kmart Corporation spun out the Borders Group, and Borders grew to over 700 bookstores across multiple countries in the world. On July 18th, 2011, the Borders Group announced their plans to liquidate and essentially went bankrupt. So what happened to Borders? This man here killed Borders Bookstore, and I suspect everyone recognizes this person. This is Jeff Bezos. And let me tell you how Jeff Bezos disrupted Borders and disrupted the book industry. So Jeff Bezos looked at the value chain for retail different than what Borders or Kmart was looking at the value chain. Let's look at the value chain for books. When you look at this value chain, at the ends are authors and readers. At its basic, what you want to do is connect authors to readers. But in the middle were publishers, distributors, and bookstores. Jeff Bezos said, instead of kind of focusing on the middle of the value chain, which Borders was focusing on in terms of growing their brick and mortar presence, growing their bookstores, growing their distribution channels, Jeff Bezos decided, I'm going to focus on the ends of the value chain, and I'm going to disrupt the center. So in 1997, Amazon.com went live, the first kind of e-commerce online bookstore. Not long after that, Amazon started their self-publishing service line. And then quickly after that, they launched the e-reader, one of the essentially Kindle, one of the first e-readers. And at this point, there was no reason ever again for a reader to ever step foot into a bookstore. But where Amazon has been super successful and continued to grow into multiple verticals, as it goes well beyond this value chain. This right here is Amazon's actual secret sauce. This is their patented Amazon recommendation algorithm. It is that simple, this formula that you see up on the screen. Let me break this formula down for you. Essentially, this formula uses machine learning. And what Amazon did, and what they were really smart, is they stuck up their 5-star review rating system on the products that they sold. And that allowed them to start essentially profiling their consumers, collect new data on their consumers, and understand how an individual consumer may look like groups of other consumers, and understand what products those other consumers were purchasing. Then they took that formula to another level. Then they really focused in on that individual consumer, and they looked back at that consumer's buying history. What did that consumer buy 2 years ago? What did they buy 6 months ago? What did they buy 2 months ago? What did they buy a week ago? And was able to kind of start looking at those buying patterns. So what is the output of that formula? It's essentially this. When you go onto Amazon, you've got your own personalized shopping experience at a click of the button in your own hands, where Amazon, in more cases than not, knows what you, the consumer, wants to buy even before you know you want to buy it. And they put those choices up in front of you with good confidence that you're going to likely click on one of those choices and purchase it. So what does this have to do with healthcare, you may ask? Well, that same company that disrupted the retail space has aggressively moved into the healthcare space, which they've been in the news even up to last month when they announced a partnership with Teladoc, where Teladoc will be providing telemedicine right into patients' homes, right off the Alexa device sitting in patients' homes. Amazon is coming to disrupt our industry. So let's apply this to where we are in healthcare as we are trying to move to population health. So when you think of the value chain in healthcare, at the ends of this value chain at its basic are clinicians and patients. Healthcare at its simplest is really how do we best and most efficiently connect our clinicians to our patients. But in the middle of this value chain, we have insurance companies, health systems, and employers. And essentially at the University of Rochester, we're all of the middle of the value chain. We are our own health system, we're our own insurer to our own employees, and we're also the largest employer in our region. However, most health systems, like the University of Rochester, are doing exactly what Borders was doing. We're investing in the middle of the value chain. Essentially, we're trying to grow our brick and mortar presence. We're trying to acquire more hospitals so we can collect more patient lives. And essentially, we're playing a game with the insurance companies, this medical loss ratio. We know that insurance companies are trying to get as much premium dollars as they can from employers, and they want to pay out as little as possible. So as a health system, the way we make money is by billing out as much as we can, especially high cost billing things like surgeries and keeping our ED cranking out patients and keeping our hospital at 110% capacity, knowing that the insurance company is probably going to deny a lot of our claims. So our focus is really not at the ends of the value chain. We are really heavily focused on the middle of the value chain. Unfortunately, telehealth and digital health really does not fit well in the current landscape of fee-for-service, and we've seen that struggle for years. The COVID pandemic has kind of ignited telehealth, and I think our health system, like most health systems across the country, essentially went from maybe 2% of all of our ambulatory visits being done by telehealth to 90% of all of our ambulatory visits within a 2-week period of time. But we need to take it further. We need to be thinking more like Jeff Bezos was thinking and less like what Tom and Louis Borders and Kmart were thinking. We need to focus in on the ends of the value chain. And how we need to do that is we need to follow what happened in retail. We need to disrupt the middle of the value chain. And how we're doing that in Rochester is we launched a digital transformation strategy for our entire health system, where telehealth is a piece of that larger strategy of how do we go from care as usual to being a digital first health system. Quickly following up with that, following exactly what we saw with Amazon, is we're investing a ton into data. And I'm going to talk a little bit further on how we're investing into data and how we're utilizing that data to essentially transform our health system to be well prepared for population or value-based care. So let's start with our digital first strategy at the University of Rochester. It's pretty simple. We have actually broken it up into 3 buckets. The first bucket of our strategy, which we are just about finishing up right now, is focused on our front door, which we're calling our digital front door. It's this concept of how do we seamlessly onboard patients into our health system using their own technologies, using mobile devices, tablets, and computers. And how do we make that convenient and seamless? And we're very narrowly focused in Rochester in our primary care service lines and our urgent care service lines, as they are traditionally the physical front door of our health system. And they were primed for disruption as we were kind of behind the 8 ball in regards to digital care in those service lines. After our digital front door, we're really going to move on and focus on engagement. So now that we've onboarded these patients into our health system using digital technologies, how do we keep them not only engaged in our health system, but engaged in health promotion in general using technology. We know that this is going to require multiple digital modalities, and I'll talk a little bit further on how we conceptualize what this virtual care platform will look like and how we're moving forward and setting this up in Rochester. Now, again, the important piece to all of this is data. What we're doing in the access and engagement parts of our strategy is we're collecting new types of data on our patient that years past we've not had on our patients before. We're in parallel to the digital transformation strategy is we have an enterprise data warehouse strategy. And I'll talk a little bit deeper on what that is in a moment. But that's where we're going to really transform the health system and in our community and move to population health. And the end of our strategy is where we define as value or smart health. This is where you really start to use patients' own data, and you can apply things like machine learning and artificial intelligence to develop kind of personalized care and risk stratify patients and move them through their care journey based off of their own data so they can get the highest quality outcomes most efficiently and hopefully at the lowest cost. So essentially matching the right patient to the right provider at the right time and in the right place. So let's talk about our digital front door and how we've conceptualized this. And again, before I jump into this, I want to say, we had a strong foundation. At the U of R, we've been doing telemedicine for, quite a long time. And, we've been leaders in telemedicine and in pediatrics and psychiatry and neurology. Well before the COVID pandemic, and which allowed us, when the pandemic essentially hit, to turn the lights on for our entire health system. But once things started to settle down, we needed to think broader than just telemedicine alone. And we needed to think of other ways to make that access into our health system easier and more convenient and more equitable for more patients. So the first thing we did was we actually stood up a chatbot, and we did this for several different reasons. First was we learned during the pandemic that our patients really love chatbots. We use chatbots to essentially screen for COVID symptoms. We use chatbots to help with vaccine scheduling. So we partnered with a very promising startup company out of the West Coast that had a really eloquent natural language chatbot that we stood up on our external website. Now, this chatbot served as essentially a virtual patient care assistant. It could do several things. It could answer frequently asked questions. How do I pay my bill? How do I find a provider? How do I schedule an appointment? But the really cool thing and the really key thing of this chatbot was it helped patients sign up for our patient portal. Full disclosure, we're an Epic health system. So, we really wanted MyChart, which is the patient portal for Epic, to be really that technology interface for most things within our health system. But our MyChart penetration was not the greatest when we started this initiative. I think we were at about 35% MyChart penetration. This chatbot and other initiatives helped us get our MyChart penetration up to currently 86% of our patients. The other thing that this chatbot did was allowed us to start cleaning our own data. So when we wanted to think about moving to the next part of our digital front door, online scheduling, we really couldn't do it efficiently because our data on our providers was a complete mess. And we didn't know where to begin. So we leveraged this chatbot to better understand how were our patients searching for our providers. Which terms were they using to seek out a provider for back pain? I could tell you right off the bat, the chatbot got it wrong quite a bit, matching the right provider that may have had available appointments. But we met with this company on a daily basis to look at their data to see what our patients were searching for. And then we leverage our informatics teams across our institution to clean up our data on the back end, which allowed us to efficiently open up online scheduling across our system, both allowing our our active current patients within our system to schedule follow-up appointments through the MyChart portal for their providers, but we also launch open scheduling. So patients who are net new to our system could find primary care providers who had available appointments and schedule essentially right from that Google search engine into our provider schedules. From there, we moved to focusing on e-check-in. So this is essentially the ability to allow our patients to fully check into their appointments on their own device prior to arriving to that appointment or logging into a telehealth appointment. So all the insurance information, demographics, all the regulatory questionnaires that we needed collected, we put all of those up onto our e-check-in platform on MyChart, and patients who weren't on MyChart, we stuck up kiosks in our very busy primary care practices with low MyChart penetration. So patients could have that airport-like experience where they could check in on that kiosk, put their information in, but at the end of that check-in, they signed up for MyChart. So essentially, we're trying to put the kiosks out of business by moving everyone into mobile check-in. We then pivoted back to telemedicine. And as we've all seen during the pandemic, there's been a big move into retail health and this really on-demand telemedicine experience where a provider with urgent care needs who wants to see a provider right now in the moment, we didn't really have a good way of doing that. And unfortunately, at the time, the Epic integrated telemedicine platform didn't have the functionality to allow us to do on-demand telemedicine and seamlessly. So, we found an external vendor to partner with in terms of a software platform. We were very smart about how we and who we selected as that vendor. And it had nothing to do with who had the best telemedicine platform, to be frank, or who had the best UI, UX, or was best in class. It was actually whose platform was most integrated into Epic. And essentially, we found a platform that was spun out of the health system in the country that's Epic's second largest customer. They essentially built their own platform within Epic and spun it out, and it was perfect for us. So it's all kind of seamless within Epic hyperspace. So we've stood up both e-visits and on-demand telemedicine for urgent issues. And then after that, it goes back to that portal, back to the chatbot, and we've set up Express Online Pay. And we went from receiving our payments, which usually we average about 40%. We're now up to 70% of patients who use essentially the electronic patient portal are paying their copays now that we've made it easy and convenient for them. So getting prepared for the next part of our strategy, that engagement part of our strategy, we know that this is going to be multimodal in terms of the technologies we're going to need. We are, a moderate-sized health system. For those who aren't familiar with the University of Rochester Medical Center, we're located in upstate New York. We're a $4 billion health system. Approximately 11 hospitals. We're the largest health system outside of New York City. We cover most of Western New York. But that being said, our IT department still has very limited resources. And the one thing that we were concerned about was, how are we going to integrate all of these different digital modalities into our electronic health record? That would eat up a lot of our resources. So to solve that solution, we've actually partnered with another vendor who, again, spun out of that second largest Epic customer health system in the country that essentially solved that problem for us. And this vendor essentially serves as a power strip. And the way this works is our ISD team or our IT team only has to do one integration into that power strip. And then the vendor takes care of all the integrations for all the other digital modalities that we want to prescribe right out of Epic to our patients. When those modalities are prescribed to our patients, the data that's collected from them goes right back through the power strip and is integrated into flow sheets right into Epic so our providers can see it over time. So the things that we're thinking about in regards to engagement, digital care pathways, and be able to kind of prescribe those out, digital patient education, mobile apps for chronic disease management, mobile apps for health promotion that can be prescribed, again, right out of our record to our patients. Things like ride share, and I'll go into a minute. In my health system, we serve a very broad geographic region where we go from the inner city of Rochester 20 miles out into very, very rural areas of New York State. And transportation is a significant issue with our patient population. So the ability to offer other means of transportation that we can prescribe to our patients is going to be a game changer for us. And then, of course, the ability to prescribe remote patient monitoring out of our electronic health record and make sure that that data flows nicely back in to the electronic health record and wraps into those digital care pathways. So let's move to what I think is probably the more transformative part. And it's exactly what was most transformative for Amazon. And it's really, truly the data. And how do you make the data work for you and a health system? And, I have to laugh because, right now, machine learning and AI is almost a cliche in healthcare. I feel like there's a new AI company that pops up every day, trying to move into the healthcare space. I'll tell you in a moment, as a faculty in our data science program at the university, why AI in healthcare hasn't been as successful as we wanted to. And I'll tell you a little bit about how at the U of R, we're trying to fix that problem. So we're going to be better prepared to do machine learning within our health system. So let's look at the patient, for example. So when we think about the data that we currently have on the patient, it's for the most part all located in the electronic health record. And in the electronic health record, we have things like, did the patient arrive to an appointment? When did they arrive to an appointment? What are their allergies? Maybe imaging, vital signs, past medical history, medication lists. But there's a lot of garbage in the electronic health record. There's a lot of things that don't need to be in there, a lot of things that, are in non-discrete fields, subjective fields within narrative notes that are really hard to access. Essentially, there's a lot of variability in the electronic health record, which makes doing machine learning in the EHR very difficult to do, because at its basic, the way machine learning works is it looks for patterns in data, it looks for outliers in the data, and it trains itself to better pick up those patterns or those outliers. And when you have so much variability and so much noise in your data, the machine is going to find things that it thinks that are important, but in all likelihood are not important. To make this even further complex and a problem, things like this patient's experience with healthcare is not in the EHR. Social determinants of health, we're doing better of trying to get that data into the EHR, but typically that was not stored there. That was in another data silo within this health system. Our claims data is in its own silo. Quality data, its own silo. Resource management, supply chain data, pharmacy data, market analysis data, you heard it, all in their own silos, which makes, really understanding that patient and who they are from a data perspective really difficult to do when you don't have all that data in one place. So we've made a huge investment of breaking down those silos and aggregating all of our data into a single data warehouse. It's taken a lot of resources and a lot of effort to do that, but that has allowed us to start getting standardized terms for the different data fields, like length of stay. Length of stay, the way we define length of stay as clinicians is different than the way, our financial people define length of stay and our quality people define length of stays. So coming up with standardized ways of defining all of our data has also been a huge thing. And so a lot of aggregation, a lot of data cleaning, which has allowed us to identify where do we have gaps in our data and where do we need to fill those gaps. So we, again, get a better understanding of who our patients are, so we can develop our own Amazon recommendation algorithm to individualize or personalize the care for the patient. So we all want to become a smart health system. We're all talking about that. Delivering personalized care using data. And there's a lot of promise there. Let's talk a little bit about that promise. And I'm going to start with a company in my backyard, started in Binghamton, New York, IBM, one of the world leaders in data science, world leader in computing, world leader in data science, had more data science expertise really probably than anyone else in the world. They launched a couple of expert computing systems. Their first Deep Blue, beats a world's chess player. A lot of promise. Their next version, Watson, won on Jeopardy, beat some of the best Jeopardy champions ever. And then after Watson won on Jeopardy, IBM said, we're going to go after healthcare. And they made some pretty ambitious goals like we're going to use machine learning to essentially match the right cancer therapeutics with the right patient in cancer care, and hopefully maybe make cancer diagnosis faster and maybe even one day cure cancer. And what the IBM then did is they invested heavily in healthcare. They spent over $4 billion purchasing healthcare data sets, some of the biggest healthcare data sets in the country, spent $4 billion buying EHR data, claims data, had access to, government publication databases. And what has happened? Within the last year, Watson Health just sold pennies on the dollar to a private equity firm. So essentially, IBM is kind of closing up shop on their big ambitions of using Watson, which won at Jeopardy, to essentially transform healthcare. So why did Watson fail? Again, it gets back to the data that we have in healthcare doesn't set up nicely for machine learning. Again, too much noise, too much variability. It sends the computer down the wrong direction. So how are we trying to prove that at the University of Rochester? Well, one of the things that we knew at the University of Rochester is we didn't really know our patients. We didn't really know them from their own perspective. Again, we knew their labs, we knew their diagnoses, we knew their meds, we knew their imaging, but we didn't really know the patient from their own voice. A lot of folks don't know about us at Rochester is we're the home of the biopsychosocial model. So we decided, we need to start profiling our patients. And we made this decision about 7 years ago at this point and said, we need to understand who our patients are from their own voice. But where do we start? And we said, well, let's start with the biopsychosocial domains. Let's understand how our patients are feeling from a physical functioning lens, from a psychological lens, and a social functioning lens. And what we did is we just leveraged an initiative that was happening at NIH called Promise. So essentially what NIH was doing at the time was investing, billions and millions of dollars into taking these complex multi-item psychometric scales that we all have in healthcare, and some of them are 30, 50 items long, and they're burdensome on patients. And how do I apply things like item response theory and computer adaptive testing, where my patient only has to answer maybe one or two questions within that scale, and I'll have enough data to really understand who that patient is compared to the general population norm. And so they've spent, again, a lot of money in investing and a lot of research and moving a lot of psychometric scales into these computer adaptive tests. We leverage that. So we essentially put these computer adaptive tests onto iPads. And so if you came into the University of Rochester, and it didn't matter what you were coming in for, it could have been a toenail injury. This is well before pre-pandemic. You got handed an iPad at time of registration, and we asked you about your emotional levels. We asked you about your pain interference and your physical functioning, and we asked you about your social functioning. We then integrated that system right into Epic Hyperspace. So our providers could see over time, and every time these patients, our patients hit our health system, how they were doing on these broad domains within Epic Hyperspace. But what this has really allowed us to do is it's created a huge foundation of systematically collected data on our patients from their own voice, from their own lens in these broad domains. We now have the largest patient-reported outcome data set in the entire country. That is the data set that we use as our foundation for all of our machine learning work. And so depending on what question we're going to ask, we're going to pull in other data points from our enterprise data warehouse. So from our EHR, claims data, supply chain data based on the question we're trying to ask. But more times than not, we're going to have that PRO data set as our foundation in it. It's allowed us to do some really great things. Like, one of the first value-based or population health reimbursement models that our health system got involved with, which most health systems got involved with, were joint bundles. And so before we got involved with a joint bundle, and those of you who are not familiar with joint bundles, essentially you get a capitated rate for a patient for their time they have an acute joint injury to the time they recover. So the faster you can get them to recovery, the money you kind of save in that bundle is yours as a system. So it's really, again, trying to encourage you to provide the right efficient care to your patient after that injury. So the first thing we were asked to do is, okay, can we look at our data to determine what is the highest cost of a joint bundle if we were to get involved with this today? No surprise to many, it was getting put into a skilled nursing facility for rehab after surgery. So then our leadership said, okay, can you predict pre-surgery who's going to get put into a nursing home? We leveraged that PRO data set. We pulled in other data points from our model, and we were able to develop a model with 92% accuracy that was going to predict pre-surgery who would go into a nursing home if that surgery was to be cut today. We then built within our EHR essentially a risk calculator for our surgeons to see. And so that dial you see on the right is essentially the percent likelihood. If you were to cut today, this is the likelihood this patient's going to go to a nursing home. Our surgeons could then play with modifiable risk factors within the EHR and essentially do simulations like things like social supports and what if I got behavioral health supports around this patient, or what if they lost weight, and could see what that would do to the model. And so they would make better decisions on who to cut and when to cut, which essentially allowed us to provide better care and saved us a lot of money in those joint bundles. And not surprisingly, having social supports for your patients in their homes before surgery was essentially the data points that made the biggest impact on reducing skilled nursing facility risk. Other things that we've done with our data, more on the telehealth side, is, again, we've collected all of these PRO data on all of our patients. What we've then done is we've geocoded every single one of our patients. So we've geocoded all of their addresses and then essentially created these heat maps. And the heat map that you see here is essentially depression or mood, emotional distress symptoms of our patients at the University of Rochester. We can hone right in to the neighborhood level of where our patients live and understand who is depressed and who is not depressed. And again, really hone in right to that individual patient. This allowed us to do some really cool things when it came to telemedicine. It allowed us to make smarter decisions of where to deploy our telemedicine resources. You know, the one downfall of telemedicine is it's still provider dependent. And I still only have so many psychiatrists in my health system to meet the care of patients on the other side. And so we had to be smart of where we set up our telemedicine suites to meet our patients. We used our own geocoded data to make those strategic decisions. What you see here is our Medicaid population, which is about 20% of who we see at the University of Rochester. They were, during the pandemic, our biggest utilizers of telemedicine. And we saw Medicaid patients, and all those dots on the map are Medicaid patients across our region that engaged in telemedicine. So it gave us a good indication of where our Medicaid patients were coming from with telemedicine. But we then were able to geocode on top of our data things like the social vulnerability index, the area deprivation index, so we could, again, better understand our patients. And what we actually learned was, our Medicaid patients engage more in telephonic telemedicine than video telemedicine. And it didn't really actually matter if they engaged via telephone or video. It actually had major impact on their downstream outcomes. We found that they had much lower no-show rates and cancellation rates. We also found that they were going to the ED less when they engaged in telemedicine, and utilized less lab orders and required less follow-up visits. And actually, we have a pending article in the New England Journal of Medicine Catalyst. It's in press right now, where we're going to present this data in depth. But again, it shows you the power of data and allowed us to better understand our patients. Let's take it a step further. So we all want to meet our patients in their own communities, and ideally we would love to meet them in their homes. But again, what we found in our community was, it wasn't that we didn't have good broadband access in our rural areas. We had good broadband access down in these rural counties, except our patients, especially our low socioeconomic patients, they couldn't afford the internet in their home. And so the only internet that they relied on was their data plans on their cell phones. And those of us who use our own data plans on our cell phones know, when you're streaming a video conferencing feed, that kills your data plan. So, again, our Medicaid patients and our low socioeconomic patients, they engaged in telemedicine, but they did it via telephone and not video. So the thought was, okay, well, can we set up suites, or, are there places that we can bring specialty care into these communities where we have Wi-Fi and we could put essentially telemedicine hubs or kiosks in? What you see here is essentially the primary care practices in the University of Rochester's network. What we found outside of the city of Rochester, Monroe County, where our tertiary or quaternary hospital sits, about 75% of our patients, 70% of our patients live at least 5 and 40% 10 miles away from the closest primary care practice. When you go to our urgent care practices around the area, it doesn't get much better. It's about 75% again of our patients outside of Monroe County live 5 to 10 miles away from the closest urgent care practice. So, delivering specialty telemedicine care into these brick and mortar practices was a great idea, but we never got the volumes that we hoped we could, because again, transportation is a major issue for our patients. Let me tell you what I think was the most disruptive thing that's happened in healthcare since the pandemic. The most disruptive thing that's happened was in July of 2021, when Dollar General came out and said they had hired a chief medical officer at Dollar General, and they wanted to become the leading provider of rural healthcare. Let me show you why that potentially is going to be so disruptive. We geocoded all of the Dollar Generals in our primary markets to our patients. We found that 85% of our patients outside of Monroe County live within 3 miles of a Dollar General. So think about that. Opportunities for telemedicine and disruptors in the healthcare space. Dollar General is primed to disrupt population health. Now, they haven't really announced or formalized what their strategy is. I've had the opportunity to talk with their CMO, Albert Wu, a couple of times. They're still figuring it out. But what I'm saying is kind of keep an eye on Dollar General and where our patients are located. So let's talk, briefly here at the end of where I see the future are going. When we think about machine learning, where machine learning has been really successful is in computer vision, because images are pretty consistent in regards to that data. And on our innovation side of our health system, we're partnering with some really early startups that have some pretty cool and interesting technology, including a startup company that essentially can collect vital signs, all vital signs, blood pressure, pulse oximetry, heart rate, respirations, all just using the camera on the phone, essentially just using computer vision. So they've done this in web conferencing platforms and just, iOS and Android cameras on phones. Like that's going to be a game changer, in my opinion, for telemedicine. One of the things that we have difficulty doing, especially in primary care delivering telemedicine, is collecting those vital signs that we need to report back for regulatory purposes when we deliver telemedicine. So having that functionality, it could be huge, and it will totally, in my opinion, disrupt the remote monitoring or remote patient monitoring space. So all those peripherals, Apple Watches, Fitbits, sensors, that smartphone that we all have, is very quickly collecting the exact same data that all those peripherals are collecting. So keep an eye on that. Another area that we've looked where computer vision and we're kind of looking to innovate is with telesitting, specifically in the home setting and in the hospital. And so, there's another kind of innovative startup company that we're working with called Cherry Labs that essentially built a computer vision model where you put cameras up in, let's say, the patient hospital room or the patient home. It keeps it private because, as you saw, it turns the patient into a stick figure. But the AI can predict, before even a human eye can predict when a patient is potentially doing a risky behavior or potentially going to fall out of bed, and alert the human to take a look at that camera to potentially prevent that fall. So, traditional telesitting services, you have one human watching, let's say, 5 cameras at a time. Think about the potential of having an AI watching 200 cameras at a time and flagging which cameras that human needs to look at. Now that could really relieve some of our staffing problems in the hospital. The other area where a lot of innovation is happening in the digital health space and with high potential in the telehealth space is virtual reality. And this is an area that we're doing our own development as an incubator and partnering with a lot of VR companies, including Meta, which owns Oculus. So we've built our own VR applications for our patients. We've also figured out a way to hack into the sensors in the VR headsets, and we can collect the patient's heart rate and respiration rate in real time with just the sensors in the headset alone. And we as a university have some patents around that. And, that is going to allow us to potentially provide, mindfulness or meditation to our patients and adjust those environments, again, based off the patient's own vital signs. Now, when the pandemic hit, I sent all of my, a good portion of my staff in my innovation incubator home with Oculus headsets. So about 15 of us, we're in our Oculus headsets, trying to do our innovation work from our homes, all in the same room, interacting with each other. Now, the technology still has a little ways to go, but you can see the promise there. We've rolled out VR in our clinical service lines, and in a second here, I'll kind of show you a success case that we have had in pediatrics. One of the areas that we've had difficulty in pediatrics is some of our children have, behavioral health comorbidities or developmental delays, and some things as simple as getting a COVID vaccine or getting a blood draw is so difficult for them that we have to use general anesthesia and knock these kids out to get that blood draw, which is not good care for us, not good care for the patients, and we wanted to disrupt and change that. So we built our own kind of VR application specifically for kids. We put them in this kind of aquarium space. They can use the microphone on the VR headsets to blow bubbles at fish. And I'm going to play a video here for you shortly so you can see what it looks like and this impact on actually one of our patients who allowed us, and the mother allowed us to share this video with permission of the impact that this has had on some of our children.
Even though he is wiggling around a lot, he is still very interested in what is going on in the video, and he's not hitting. He's not, as you see, he's tapping it, but usually he'd be trying to bite and smack everyone else. Are we all done, or do you want more? Do you want more? Okay, put it back on.
Thank you.
And it's very easy for him. Usually with his grasping, it's hard to use anything. So with the cushion, it's very textural, easy on his face. And like I said, he usually is trying to go after whoever is trying to do any sort of procedure on him.
Yeah.
So he's more into this than what's going on with his body.
It's very interesting. Thank you.
You're welcome.
Yeah, again, the next spot, I think where there's going to be, significant opportunities, especially for telehealth, is in the speech recognition space. I mean, we have already seen Amazon Care announce the partnership with Teladoc and the ability to essentially ask Alexa, I need to see a doctor, and get services delivered right into your home from Teladoc providers. So a lot of opportunities here, and when I'm kind of thinking about a space that we're trying to innovate, it is in this space. So with that said, I would like to open it up for any questions.
Thank you, Michael. Thank you for a great talk. And I will say that we have a few minutes here. There's at least a couple of questions that have kind of pre-populated throughout, but folks are welcome to throw your questions in the Q&A box, and I'll read them out to them. And so the first one here, I was reflecting on the beginning part of your conversation around how important it was to make sure things were fully, integrating into your EHR. Could you talk a little bit about some of the best strategies and best practices that you found in terms of engaging the vendors, the EHR vendor, but also the platforms that you're talking to, and the questions you're asking, maybe?
Yeah, so that's a great question, Reid. Engaging the EHR vendors are difficult. We've got two major EHR vendors, Epic and Cerner, and they're really good at what they are, EHR vendors. Things in the kind of innovation, digital health space, they're starting to innovate there. They're starting to move that way, but it's not their bread and butter. And, they're not quick. Let's just say that. The opportunity for integration into those EHRs for a lot of vendors could be quite expensive because you've got to go kind of work with the EHR in general to get that integration integrated into, let's say, Epic's App Orchard, and it's a lot of times cost prohibitive. Fire interfaces are making it a little bit easier to integrate in. For us as a health system, we look to the leaders in the field, and one of the health systems that I really look to is Providence Health out of Seattle. So I referenced them a few times, the third largest health system in the country. They had the second largest Epic customer in the country. They have a $300 million venture arm to their health system. And what they do is they develop, solutions within Epic, that fill gaps. And then they spin out these companies, they invest in them. And, if it was a problem for them, it's probably going to be a problem for me. And so, I work really closely and learn from them, and, kind of fast follow the solutions that they're creating. And for us, again, you might be the best in class vendor in the space. If you don't have a seamless integration into our electronic health record, we're not going to look at you.
Sure. I think that's really helpful. I'm just scrolling here to see what other questions we have. Oh, here we go. We have two. I'm trying to juggle how to ask them. I think we can kind of ask them I'll ask them simultaneously, then you can answer them as we go. So the first one was, could you talk a little bit more about the chatbot integration process you looked at? And if, I think you'd mentioned that there was more than one, maybe some differences you considered. And then the second one was any further elaboration you had on how you thought Dollar General might be thinking they'll plan to interact with their customers, whether or not you thought it might be point of sale, or is it more through their app or things like that? And yeah, curious your thoughts.
Sure. Yeah. So, the chatbot space, our incubator, we essentially built our own chatbots when COVID hit. I actually think we got a chatbot out before, Carnegie Mellon and Facebook did, and Stanford got theirs out before chatbots were really cool. And we quickly learned that our patients really liked it. However, given all of the digital transformation that we had to do as a health system, for us to continue building our own AI chatbots was just not sustainable for our small innovation incubator team. And so, we were very lucky. Again, a lot of innovation happens out on the West Coast, and they're in much more capitated markets out there. So they're ahead of us on the East Coast. And so I was able to look at some of my partners out on the West Coast, and we happened to find an early, a nimble and agile natural language processing chatbot company. We really liked their interface, and we elected to partner with them to kind of take some of that load off of us. So we were continuing to build our own chatbots, and it's been fantastic working with them. And in regards to Dollar General, that's a great question. I mean, Dollar General, after making a big kind of announcement that they were hiring a CMO and they were, going to transform healthcare, it's been really quiet. Their CMO, I think, is really getting his feet on the ground. They haven't really come out with what their market strategy is going to be. I mean, they have moved on the product side to bring more produce into their stores and trying to be healthier. They have announced, I think they're going to bring dental supplies into their store, and, maybe some over-the-counter medications. They're, again, major concerns that could cause other health deserts, especially around pharmacies, because Dollar General's costs are just so much cheaper than everyone else just with their business model. And that will essentially potentially cause other pharmacies like CVS and others to not want to open up shop in towns that Dollar General is in, given they're not going to be able to compete on the same margins. I think they have a prime opportunity, of partnering with health systems in the country, partnering with ACOs in the country, and allowing the health systems to deliver telehealth services into their brick and mortar retail stores, even potentially of developing kind of risk arrangements with Dollar General in itself to do that. So, I think that it's fairly wide open. It'll be really interesting to see what they do. I mean, it's similar to the Walmart health model in some ways in terms of potential, but Walmart does not go into the towns that Dollar General are in. Dollar General's business model is specifically opening up brick and mortar stores in populations with less than 10,000 people. So you're not going to see Walmart or Targets kind of moving in those areas. So you talk about health disparities and social determinants of health. They have the brick and mortar reach to really make a big difference in some of our most vulnerable patients. So I think the eyes are going to be really on them to see, how they do this, and, hopefully they do it right.
Sure. And I know we're pushing on time, and Ari, I'm going to turn it over to you in just a second, but I've been thinking about this since last time we saw each other in September, when you bring up just how, phones have all this technology that we're kind of finally seeing the potential and the ability to work with and potentially interact with. I've been thinking about technology, and telehealth initiatives that maybe the landscape is now more permissive for the possibility of, right? And so like a simplistic example would be QR codes. When they first came out, there was really nobody that had the app, right? Or things like that. And now almost all smartphone cameras are instantly going to recognize that. So if you take that larger, like are there things that, you're spinning around in your head that maybe technology innovations that were tried in the early 2000s or the early 2010s that now there is better capacity software wise and hardware wise.
Yeah, absolutely. I mean, technology just moves so much faster than healthcare. Just cloud computing. We see all the big tech companies. AWS, Microsoft Azure, Google Cloud. Just cloud computing alone, and will allow us to do some pretty awesome things in healthcare from a data standpoint. It's just kind of getting to that level. Most of us that have large health systems, our technology and our data sit on on-prem servers, which really limits our computing power and our ability to scale. And it's just starting to feel that comfort level of moving, especially our PHI, off of our on-prem up into the cloud. But once that will happen, once that tipping point happens, the power of cloud computing is combined with potentially more data and better data. It will really, I think, improve care tremendously in our country.
That's awesome. I think you're appealing to my inner data nerd. I do know we're at the top of the hour, and so I am going to turn it back over to our colleague Aria to close this out.
Thanks, Reid. I'm just going to bring up the closing slides. Just a reminder that our next webinar will be held on Thursday, May 19th, and that will be on integrated patient portals and improving the virtual experience. Registration information is available on the events page of the NCTRC website. And then lastly, we do ask that you take a few short minutes to complete the survey that will pop up at the conclusion of this webinar. Your feedback is very valuable to us. Thank you again to Dr. Hasselberg for his presentation today and to the Northeast Telehealth Resource Center for hosting today's webinar. Have a great day, everybody.